Okay, so I will go live on Facebook. Give me a moment or two, or maybe a minute. I want to post this in Learning General Surgery. Okay. While they are setting me up, I will go on to my presentation and hit play. So Rajiv, can you see the first slide?
Yes, sir. Yes, sir.
Okay. So can you see my second slide?
Oh, yes.
Awesome. So I'll just check that Patta is ready, and I think can somebody check if it's there on LGS on Facebook? Rajiv, can you check that?
Yes, sir. I'm on it.
Yeah. So in case you've logged in just now, I'm going to give a pretty detailed talk on eTEP access, which basically means everything eTEP. So we will be talking a lot about the fundamentals as well as go into detailed technical steps. Most of it is technique based
Yes,
and
so you are
practical.
on.
All right. So
LG.
in which case, I think we start. Okay.
Okay. I would want you to browse through your slides.
Yeah. So my slides are moving. Can you check both here as well as on LGS?
I'm checking on LGS.
Yeah. Okay. So it's happening on Zoom, correct?
Yeah, morning, Dr. Ramana. I'm sorry to be late. It's working well on LGS and Zoom as well.
Awesome. So shall I start?
Yes, yes.
Wonderful. Okay. So today we are going to discuss eTEP access, and I cannot start without acknowledging the history behind it. In 2009, a Colombian surgeon by the name of Jorge Diaz first described this operation for inguinal hernias. Now, he described it in Spanish first, as many of those innovators in Latin American countries do. And then around 2011, he published it in English. And in 2015, by 2015, it became more or less established amongst a small group of surgeons as a good procedure for sliding hernias or recurrent hernias. And that is the beginning of the eTEP access. It started for inguinals, and subsequently Jorge Diaz has published a lot of articles as well as written book chapters on this. But the field really exploded after 2015 when Igor Belyansky, a surgeon based out of Annapolis in the US, published LAPTAR, which was initially a transperitoneal approach. And very quickly that became modified and became an eTEP access TAR, as well as a Rives-Stoppa operation. So this started in 2015, and I got into this when I started discussing with Igor about the pros and cons of the approach. And we started working together. And in 2017 September, we published around 80 cases. I contributed around 24 of them. And once this got published, the procedure really took off. Surgeons across the world have become very, very energized and enthused to take up eTEP for more than one reason. So we will discuss the pros and cons of all of that. So what are the access advantages? You know, if you go in through eTEP, what are the advantages? One is, if you're doing inguinals or even ventrals, your exposure becomes very wide. The entire abdominal wall is potentially accessible through your ports, okay? It tolerates pneumoperitoneum for inguinals especially, so that becomes a big advantage over regular TEP. Even in obese patients, this is an advantage. Usually the retrorectus plane is unspoiled, it is virgin. So even in recurrent hernias, the eTEP is usually not a difficult plane to get into. When there are multiple hernias, whether that's an umbilical hernia with a lateral hernia or bilateral inguinal with an epigastric hernia or an incisional hernia for that matter, you can handle all of them by one access. Now, the basic premise of eTEP is that you basically cannot let mesh and bowel get together because you have long-term complications. I mean, when I say you cannot, I mean, this is not desirable, especially if the patient is young, then there's a lot of time for the bowel to make friends with the mesh. So ideally, extraperitonealize that mesh, okay? The retrorectus plane is the best because it is vascularized, it is concealed from the skin. I've discussed all this in the previous AWR overview talk. When you don't fix the mesh, which we generally don't do in eTEP, you have less pain, early recovery, and better quality of life in the short term. And overall, if you do a Rives-Stoppa operation by minimal access, it's wonderful. The eTEP is possibly the best approach for inguinals, and the benefits of that is we generally avoid going into the peritoneal cavity, and so bowel injury chances are less, and there's a lower risk of trocar site hernias if you don't go into the peritoneal cavity. And you basically are replicating the Rives-Stoppa operation and the principles through minimal access. And you get unsurpassed views of the inguinal region. If you're an inguinal hernia surgeon and you're using eTEP, once you divide the arcuate line for a couple of centimeters, that whole space opens up and gives you a phenomenal view of the myopectineal orifice, and you can actually put in bigger meshes and have less recurrences. So the eTEP access techniques can be by just very low-tech open port. You can use a PDB balloon or spacemaker balloon. You can use an optical trocar like an XL or an applied medical trocar, which is also a very good way of doing it, and a specialized optical trocar, which is called Visiport, and I will show you that. So this is an optical entry through a 12 mm optical trocar, and you can see the anterior sheath, the rectus muscle, and you see the posterior sheath there. Then you drop your hand and go parallel to the posterior rectus sheath, and you have to be careful here because your trocar, your current trocar, does not allow insufflation till it is fully inside. So that is a pain. You risk injuring the peritoneum by doing that. Anyway, this is a comparative picture between the balloon, the blunt entry, and the optical entry. And you see that the balloon has greater cost, the blunt is the cheapest, and the optical is very, very efficient, but needs a little bit of skill. So when you go in through the optical trocar and you take the trocar out and pass the scope back, you might find that the scope has gone into the wrong plane. It's slipped out. Okay. So another common problem is a peritoneal rent. Now, the chance of this is higher if you're doing a workshop. Okay. So once there is a pneumoperitoneum, then your whole procedure becomes difficult because the pneumo pushes the peritoneum and posterior rectus sheath against the wall. And your trocar may actually come into the subcutaneous tissue, and you might be searching to put in the other ports, and you simply cannot figure out why you're unable to put in another port. So these are some common problems which you have when you're trying to put in optical trocars. Let's talk about the eTEP RS as an operation here. Now, this is a visiport. So this black line is the knife. This is subcutaneous tissue. And you can see we have incised the anterior rectus sheath. The rectus muscle comes in. We just move it. We split the muscle. We split the muscle and we can see the beginning of the posterior rectus sheath. Then we depress the port and go in. And the insufflation starts once you're inside. It opens up the space immediately. So you can actually go in and divide some more fibers of the areolar tissues here. And then you take the trocar out and pass in the scope and do dissection with the telescope. Before long, you have the initial space which is visible. You can see some perforators and a needle tells you where to place the port. That port is placed just medial to the linea semilunaris through the lateral part of the rectus muscle. You can use any device to create space. This is a bipolar instrument. It's not a seal cut, which is a very nice thing to use. This is simply a bipolar, and it is being used to divide the small vessels and make space for the third port. So this is the third port. I use only 5 mm ports for assistance. There's only one 12 mm, everything else is 5 mm. The hook diathermy is a very useful and elegant instrument which gives you precision while you're doing your dissection. So this is the space creation within the retrorectus tunnel. Okay, so you have 2 operating ports now and 1 camera port. And you can see that the space is being created towards the midline. You don't need to worry much about the midline dissection. You can see the inferior epigastric. We are looking from above down, and the retrorectus dissection now goes towards the inferior limit, which is the cave of Retzius. So you stay in the same plane as in TEP, and now you shift the camera to the lowermost port, and through the uppermost port, you pass a hook diathermy and do the midline crossover. So this is the upper crossover, and you can see we are dividing the posterior rectus sheath of the patient's left side, and the yellow fat is the falciform ligament fat, which has been pushed down, and we are now trying to expose the undersurface of the PRS of the right side. So once you expose the PRS of the right side, make sure to incise at the right place where the muscle is there. Don't incise the linea alba, as that will be an iatrogenic injury leading to an incisional hernia recurrence there. So you can see that we are incising it right where the rectus muscle is present. Now your incision now will have to be longitudinal in the direction of the linea alba, parallel to the linea alba. So the grasper is holding the posterior rectus sheath of the right side, and the hook is creating some more space, allowing the 4th assistant port. This is the first port which goes on the other side of the surgeon. So the surgeon starts typically on the patient's left, and this is the port which allows you to now triangulate and take down the PRS on either side along with the central falciform fat. So what happens is, when you keep doing this on either side, divide the PRS a bit on the right, then push down the central fatty falciform and the peritoneum, and then divide it on the other side. You keep pushing down all the peritoneal contents with an intact layer of peritoneum and fascia transversalis, and expose the linea alba at the top of the screen. Okay, so this is retrorectus dissection on the right side. This is division of the PRS on the right side. The camera is at the upper left. So you're looking down, and you can see that the PRS is increasingly be pushed down, and we are staying extraperitoneal throughout. Care is taken not to go into the peritoneal cavity or into the linea alba. So the hook gives you very, very precise lines of division, and now you can see more and more space is available for the surgeon as you continue the same process of dividing the posterior rectus sheath till you reach the hernias. Often you get more than one hernias, and you just keep pulling the contents down and dividing these vascular strands on either retrorectus compartments. And very soon you see that your pelvis is connected to the bilateral retrorectus compartment. There is a small bit of peritoneum which opens up when you can't take down the sac intact, which is most often. So a little bit of peritoneum is very easy to close. You don't necessarily need to close the posterior rectus sheath. We will, of course, discuss that anytime, where you don't need to close the posterior rectus sheath as it is not a strength layer. But if you close it, just ensure that there is not significant tension involved there. So here we are closing the posterior rectus sheath. It's a small gap, so I really don't think it matters much. So these are nice chunky bites to prevent bowel from coming out between the stitches and from the stitches cutting through. So that's closing a small bit of peritoneum. And this is the reverse bite that locks the V-lock suture. So that takes care of the PRS. Now look at the midline defect, the diastasis, and the linea alba. Now, admittedly, this is a very, very simple case. It's a very small defect. There's not any significant diastasis. This is, I don't recall exactly what was the indication for an eTEP here. Could have been patient choice, could have been something else like part of a workshop or something. Whatever it is, this is a good case, in my opinion, to demonstrate technique. Now you see, this is the linea alba division going through the loop of the V-lock and simultaneously going in through the linea alba prevents the needle slipping out of that hole. So that is one of the techniques which you can use. And the reverse grip on the needle is what is most useful. I still see people doing suturing with the needle held conventionally for a right-hander, but this is the correct way or more optimal way to use the needle. And when the needle is lodged into the other side, you grab it once more with a perfect alignment. So it becomes a very quick and elegant way of changing the bites, going from the first bite to the next bite, and it saves a lot of time. If the needle keeps moving here and there, then it becomes clumsy and tedious to do the operation. So if you see this, the bite is precise every time and don't go into the muscle, okay? You prevent taking a bite through muscle that will lead to bleeding. So this is now bite on the upper part of the linea alba, subxiphoid, and now coming down. So you have to start from below up and then from above down. So you can see that we are looking from below up. That is the area of the xiphoid. That is the first two bites. And typically, I would place a port on the opposite side, which means this would be the second contralateral port. So I would have a bilateral instruments and triangulation. So the suture now goes from top down and meets the other suture line, the one which has finished in the center. And you reverse that and you're done. This used to be the most difficult part of the operation before, but it's become much, much simpler with experience. So now you put in a scale and measure the area that you have to reinforce with the mesh. So you have to do the measurement in multiple levels. And typically, you would need at least a 23, 24 centimeter long, if not 30, 36 centimeters, depends on the patient's height. And the width is minimally around 14 centimeters and may go as much as 17 centimeters or so. So standard macroporous polypropylene mesh is used and may not be fixed at all. Because once you take the pneumo out, if the mesh is well laid, then it just gets sandwiched in this plane. Okay, so for those of you who are saying, oh, this was a very simple case and there's hardly anything there. So this is, Deepak was asking me yesterday, what do you do in a post-IPOM recurrence? Do you have an issue or not? So this is optical entry. This is post-IPOM recurrence. So that's the posterior rectus sheath. You get just on the surface of the PRS and go through the areolar tissue. Now you're inside. Now, lateral part of the rectus muscle, medial to the linea semilunaris, don't go through a neurovascular bundle if you can help it, and put in an instrument and take down the areolar tissue and avoid excessive bleeding. It just makes it a little miserable to look at. And then create space for your second assistant port. Okay. So you can see that neurovascular bundle, and we are going in just medial to the linea semilunaris for the second assistant port, which typically, each port is around 5 fingers breadth or 4 fingers breadth from the previous port. Now the retrorectus tunnel is being formed. This is the division of the tissues towards the linea alba. Remember, we are typically starting from the patient's left side and looking towards the floor as well as towards the midline laterally. Now you can see the previous sutures of the mesh, the transfacial sutures, and we are now doing the midline crossover. Okay, so you can see that the posterior rectus sheath is being divided, the fatty falciform is encountered, and then it is being pushed down. So because we have already showed the eTEP RS, I will kind of fast forward most of these places where you don't have anything new, but I will keep the video focused more on where you have the tacks and the sutures, right? So we are incising the PRS of the right side. This is the crossover and little bit of space creation to allow your fourth port, which is the first contralateral port. Okay, so from the left, you've crossed over, and the fourth port is to the right side. Right, as in right subcostal. Okay. So as we are doing the division of the PRS, now coming from top down, you can see that the peritoneum is visible, and we have to be careful here because there's not much of tissue which can prevent a breach of the peritoneum. And as far as possible, you try to avoid opening the peritoneum. So I hope you can understand what is happening here. We are keeping the peritoneal sac in the midline. We are dividing the posterior rectus sheath on the right and on the left, then creating a little bit of retrorectus space, and gradually conquering more and more territory in the bilateral retrorectus compartments. You can see that now. That's the central hernia defect with the sac coming. Now you see the tack. You can see that. So that was the tack. It hardly ever crosses the posterior rectus sheath, and it is not usually a problem to do a post-IPOM recurrence through eTEP access. As I said yesterday, I've even done cases where laparotomy wounds have been closed with stainless steel wires, and we have not had problems in removing those stainless steel wires through eTEP access. Now, these are the transfacial sutures, and we are dividing them. All right. So now I will fast forward this part. You're seeing that we are taking out the entire sac. Okay. So here we are not opening the peritoneal cavity at all. We are successfully taking down the entire sac. Now, when taking the entire sac down, please remember that your linea alba has to be at the ceiling. You must stay under the linea alba. Okay, nobody announces, no tissue is going to announce that, oh, I'm linea alba. So it's all looking like fascia, and sometimes in recurrent cases, it might all look fused and confusing. So you need to stay in the right plane. It does take a knowledge of not only anatomy, but pathological anatomy. Okay. So as you can see here, this is the posterior rectus sheath. The muscle always stays up, and what is a facial structure medial to the muscle is the linea alba. You can see the tacks here. We keep pushing down the PRS with the IPOM mesh. So this is not a case where the IPOM mesh has got bowel adhesions or intestinal obstruction. So we are leaving the IPOM mesh intact here, okay? So once you cross the hernia sac, you see that inferior epigastric, which is staying up towards the ceiling, that is the correct plane. And laterally, we are now seeing the neurovascular bundles and the linea semilunaris. So this is pretty much the same. And now you can see that the midline is exposed. We are measuring the space as before, and we are now closing the linea alba. So once again, illustrate the technique. This is one of the techniques to use the V-lock suture. So you pull it, let that hole be there, and pass the needle and go directly into the fascia so it does not slip out. Okay. Reverse bites, each bite is as precise as a robot would do it. So just avoid every bit of muscle fiber that you can. So you must visualize where that needle tip is going through. You see that? So I'm avoiding that muscle very, very definitively, very, very consciously. So this is the same as before. So you just continue closing the midline. I would recommend doing a contralateral port to close the upper part of the linea alba, but it is also okay to do it from one side, though it becomes difficult to teach that unless you are very, very fluent in ambidextrous suturing. Okay. Okay. So this is the last bit of this one. We shape the mesh after measuring it. We taper it off so it kind of becomes boat shaped. And you have to be very precise in that measurement in multiple dimensions so that you don't waste too much time in struggling with the mesh. So that is the eTEP RS for a post-IPOM recurrence. Okay, I'll now show you an eTEP TAR. There are two techniques. One is the classic top-down technique, and the other is the bottoms-up technique. Okay, so the OR setup, I will show you here. I have shown this before. You basically need a modern OT table which can be flexed. You must be able to strap the patient. You must have bipolar, monopolar, maybe a ligacure or harmonic. You must have a very good quality imaging system. Now you have 4K. HD is pretty basic today. I would recommend that your patients be well padded, and you must strap the patient, have mechanical DVT prophylaxis, and use your monitors. You may be needing to shift them towards one or the other side, maybe towards the foot end at some point. And you break the table at the level of the costal margin around 30 degrees so that your hand does not hit the patient's face when you're standing at the patient's head end. Okay. The anesthesia team must give enough space at the head end so that the surgeon and assistant can stand there. Now, there are some anatomical structures which you need to identify, and you know all of them, right? Costal margin to midline, the linea semilunar is extremely important, and the defect and the sac. All of these become important for you. The port positions are the standard approach is that you start from the left subcostal. This is a right-hand surgeon's technique. So a left-hander can do it the reverse. So you can see the marking of the second port just medial to the linea semilunaris, and then another one just below that, 5 centimeters or so below that. And the contralateral 5 millimeter port is where I showed you, where we put in after the crossover. So that is what I was talking about, this one. This gives you contralateral exposure. So if you're using the open port technique, this is the anterior rectus sheath, okay? Then you can see that the visible fibers of the rectus abdominis are vertical. Then you split the rectus and see the pearly white facial structure, that is the PRS. And then you slide in the cannula, and you can also put in your finger and create space and then part your cannula. So these steps I've already gone through. I'm not going to go through. These are the limits of dissection. Now you see laterally in the retrorectus tunnel, you can see the posterior rectus sheath is formed by the transversus abdominis, and these are the vertical contributions from the diaphragm. So the first incision is on the posterior lamella of the internal oblique and the deeper transversus muscle. So this is the internal oblique, this is the transversus. It has retracted. It should be around 1.5 centimeters from the point of entry of the neurovascular bundle, and then you get under the transversus and keep pushing the peritoneum and fascia transversalis down. And that is the lateral retromuscular space which you develop, and this is the facial peritoneal flap which you develop, okay? So this is again the access technique. I'm not going in there. And this is the initial part is the Rives-Stoppa operation, which I'm not showing. So we'll just fast forward to the part where we can actually go into the TAR. So you can see that this is the Rives-Stoppa, and we are pushing down the PRS. So in this particular case, what is of interest is the presence of a mesh as part of the sac, and that is something that we will be removing in this particular operation. All right, so the limits of the Rives-Stoppa have to be reached first before you start doing the TAR, okay? So I will now go into the TAR part. Before you do the TAR, just check whether your midline is going to close, because if you don't need to do a TAR, don't do it. Now, this is a mesh which we chose to explant. I don't recall the exact reason why we needed to explant the mesh, but if you think that the mesh needs to be taken out, please don't hesitate, take it out. But if you think it is well integrated and does not need to be taken out, you can keep it there, okay? You can now see the lamppost sign, which is the arched neurovascular fibers on the lateral part. Now that is the area you want to see. The red transversus as part of the posterior rectus sheath, and you expose each neurovascular bundles. There should be around 5 visible, okay? So stay medial to them. Don't go lateral to them. So this is the same vertical contributions of the diaphragm, and above the costal margin, you won't get any more TA, you will get only the diaphragm. So be careful there. So this is the beginning of the right TAR, and we are incising the posterior lamella of the internal oblique, and that exposes the underlying transversus muscle. You can use this monopolar diathermy also. So this is a thunder beat. And now, having divided the transversus muscle, you can see the pearly white fascia transversalis there, okay? So we are proceeding longitudinally, staying medial to the neurovascular bundles at all times. I cannot stress this enough. So go bit by bit, and I hope you have gone through my TAR talk. You can see that this is the TAR which is happening, and we have to go between the peritoneum and the transversus muscle. Sometimes this plane is sticky, okay? In open surgery, we would grab this with a mixer and lift it up and go underneath it. in lap, you can do that as well. As you go down, the transversus becomes aponeurotic and it becomes thinner, and it is crucial now to stay in a plane which avoids opening up the peritoneum. Typically, that plane is a little lateral. If you go medial, the peritoneum is more densely adherent and you can open up the peritoneum. But don't go so far lateral that you injure the neurovascular bundles. So now you see that we are trying to get that pre-transversalis plane. We're sweeping the undersurface of that aponeurosis and pushing down the fibers of the transversus along with the peritoneum. So this works with bipolar as well as monopolar. You can now see those transversalis, fascia transversalis fibers, which we are taking down. When the peritoneum is very thin and the aponeurosis seems to be stuck, it would be prudent to use a more precise instrument like the hook. So you can see here, those are the few remaining aponeurotic fibers, and that is a well delineated fleshy transversus muscle. Now we go lateral to develop a better plane. We may not have completed the TAR inferiorly, but in order to get a better plane, we can go and create a big space. Okay? This is a bipolar instrument, and we are sweeping the fibers till we expose raw fascia, raw transversus muscle. Okay? So the goal is to stay under the muscle, not to go on top of the peritoneum. Okay? This plane is typically bloody, and small veins tear off and start bleeding, but they are all self-limiting. So you can just put a gauze piece there, or you can take your time and buzz them as you go. So putting in a gauze piece is a very effective way of improving your vision and stopping the bleeding. So now you can see that upper part of the TAR is done, and the peritoneum is now hanging below. This will only increase. That's the TAR continuing. At the upper part, the transversus is divided more medially towards the midline because, as I told you, it interdigitates with the diaphragm, and you will end up dividing the fibers of the diaphragm if you stay lateral. Now here in the upper part, it was stuck. It was not getting mobilized. So we looked inside and we found that because of perihepatitis, the liver was stuck to the undersurface of the peritoneum. So this is one of the reasons for not being able to mobilize it well, in which case I would say divide those adhesions, and you will find that your dissection has gone past that hurdle. So this is a lateral exposure, which is now continuing. You can see the perinephric fat, and you go all the way till the psoas muscle, and the nerves and vessels of the pelvic floor are exposed. So you close the peritoneum with a running suture of PDS or V-lock absorbable, whatever you like. You can use Vicryl if you so fancy. So these bites must not be too thin, nor must they be too wide apart, allowing bowel loop to pop in between them. So do it as precisely as you can. And again, it is not important to bring the posterior rectus sheath edges tightly together. Now, this is the formation of the linea alba using bites as in the eTEP RS. So this part of the operation is the same as the eTEP RS. I'm just going past it. Okay, now I will rather show you the other part of the operation, which is important, which is the bottoms up eTEP TAR. So the same points, precise suturing and using the reverse grip. Yes. So yeah. So this is the mesh. when you have done a unilateral TAR, it will be a very large and asymmetrical shaped mesh, but it is important to learn how to handle it. And this is a bottoms up approach, okay? So what you do is you go into that TEP plane, the space of Retzius is exposed. You have divided the fascia transversalis under the inferior epigastric vessels. So you've gone laterally to the space of Bogros. So this is what you're looking at, that gauze piece is in the space of Bogros. This is the division of the arcuate line, and you make sure that you're not dividing the peritoneum there. So what you do is take a gauze piece in your left hand and sweep the fibers down from the undersurface of the posterior rectus sheath, and the peritoneum will go down with it. If you do this well, then you will be able to avoid peritoneal breach. And sometimes it may be difficult to do so. In an attempt to do so, you may actually end up opening the peritoneum, but try and be as precise as you can and don't be in a hurry. This step will bite you if you try to do it fast. And I would say go bit by bit and sweep that gauze piece, create that cave. Now you see that peritoneum is coming from underneath. This is the peritoneum here, and it is coming right under where you're dividing it. So unless you sweep it before you divide the transverses, you're going to end up opening the peritoneum. And when a small bit of the peritoneum opens up, then it very quickly expands and becomes a big tear. So even the technique of sweeping the peritoneum down can actually go wrong. Now you see the fleshy fibers of the transverses has started coming. That is the TAR. Now you see that we are sweeping the peritoneum off the undersurface of the transverses and going bit by bit. Now very, very clearly you can identify the posterior lamella of the internal oblique is this one. Underneath is the transversus muscle. Going fiber by fiber, bit by bit. This is from below up. This is the bottoms up approach. The gauze piece is immensely valuable. You can roll it like a cigarette. That is also another way of doing it. The robotic surgeons do it that way as well. You can see that the TAR is getting extended cephalad. And at all times, you stay medial to the linea semilunaris and the neurovascular bundles. I keep saying this, and see this as you go up, the peritoneum is sometimes stuck to the undersurface of the muscle and may tear. There you go. So once you have a tear, it can keep extending. So be quick in mobilizing it as far away as possible where you know the peritoneum is protected more. So what happens is the tension on the tear reduces and the expansion of that tear is prevented. I hope you understand what I'm saying. If you keep dissecting close to the tear will tend to keep increasing in size. Whereas if you go a little further away and bring the peritoneum down, the tension on that tear reduces and you can actually prevent that tear from becoming unmanageable. So once more, we create that subtransversus plane by mobilizing the peritoneum and dividing it bit by bit. And underneath the ribcage, you get the diaphragm and you stay in that preperitoneal plane under the diaphragm. So sometimes this tends to ooze, especially in bilateral TARs in a difficult procedure. No problems. Your picture will temporarily become darker. So put in gauze pieces, soak up the blood, suck them out, and start again. So your picture will improve. So once the TAR is done, you close the peritoneum. And this is the same step as in the Rives-Stoppa, except that typically the peritoneum is the closure is much longer. And one important consideration is that the peritoneal sac must be on the floor. It should not be tented up. It should not come down from the sides. It should lie flat horizontally on the floor. If you don't have that flat, it means there is still tension on the suture line. You see that? That should be horizontal peritoneal fold. So typically these patients are, like enhanced recovery without trying to do so. So the patients go home within 15 hours of an extensive surgery. Even if it takes 5-6 hours, the patient goes home. Now, this is for students and those who have a methodical, systematic mindset to learn things step by step. So you have 10 steps to eTEP, 10 steps to gastric bypass, that kind of stuff. So this is 22 steps to eTEP, okay? So just going through the points. The first thing is review the case, okay? This is very, very important. Say, for example, in this case of incisional hernia, you can see that the flat muscles have got divided. There is an intact external oblique here. So this is an interparietal hernia, and there is an intact mesh here underneath which there is bowel, and here there is fat. So you have omentum here and you have bowel here on the undersurface of the mesh. So you are pre-warned that this part is going to be difficult, and you should not be too adventurous or careless when you're doing a dissection in this area. Part 2 is identify all the landmarks. If there are multiple hernias, mark them, and definitely mark the linea semilunaris as accurately as you can. The third is you put in the ports and get into the retrorectus space, make space for additional ports. Then you complete the retrorectus tunnel on the left side, do the crossover. Then you place the fourth port. Then you demonstrate the cardinal eTEP signs. So what are the cardinal eTEP signs? This is the volcano sign, where you have the central falciform fat with the peritoneum underneath. This is the PRS divided edge of the left. This is the PRS divided edge of the right. So the camera is looking from above down. The second is the lamppost sign, which is the neurovascular bundle arching up to the ceiling. This is the musculo-aponeurotic junction of the posterior rectus sheath, showing the transversus abdominis muscle covered by the posterior lamella of the internal oblique, and this is just the posterior rectus sheath. This is the same volcano sign shown even more elaborately. At the xiphoid, there is a subxiphoid fat, and the divided edge of the PRS on either side leads to the appearance of the frenulum of the prepuce. So this is called the frenulum sign. You next do the adhesiolysis, which is an extremely crucial part of the operation. After reduction of all the contents, you complete the Rives-Stoppa dissection, and now you assess whether you need to remove mesh, whether you need to suture some seromuscular tears, whether the midline will come together without tension or not, whether you need to do more steps. So these are your assessments, and if you choose to do so, then you do the right TAR, okay? Once you do the TAR, create the retromuscular space, go all the way to the psoas. After that, ensure hemostasis is achieved. Then you reassess your work. Do we need to do a contralateral TAR? So does this case merit a bilateral TAR? If not needed, don't do it. But if needed, don't hesitate. Then close all the holes. Be meticulous. Look from different angles. Put the scope through the upper port, through the lower port, the middle port. Don't miss out on peritoneal holes. Then you reconstruct the midline. After you do that, measure the space and then carefully tailor your mesh and deploy it. You close without drainage. Now, you may choose to close with drain. I will address the drain, no drain issue subsequently. And I have some interesting findings to share once our data gets published. Before that, let me just say that I don't train. If you want to, you can go ahead. Please do not let insurance or any authority tell you that this is just a hernia operation. This is not just a hernia operation. This deserves respect. It is high-end, minimally invasive abdominal wall reconstruction. It has multiple steps, multiple risks for the patient. You must treat it as a major procedure. So make sure that the procedure is coded for being what it is, not just a routine hernia operation. Keep close follow-up. So this is step 22 of the catch 22 for eTEP, because without follow-up, you don't know what you're doing. So this is crucial that all your patients are reviewed and you check how they are looking functionally, how they are behaving functionally, whether they can get up or not, whether there's a bulge or not, whether there's a recurrence. And this is something I showed. It's one of my favorite post-op images, a very, very solid abdominal wall after a bilateral eTEP TAR. So you may have many thoughts. You may have many questions about this subject. So you may say, you may ask, what are the indications? When would you do eTEP for ventral hernias? What are the cases where you would not do eTEP ventrals? What are the problems? There are plenty of critiques for the eTEP approach. What are the complications? Don't you have complications when you do eTEP ventrals? And have you done any changes in your technique? Those who have been with me over the years have probably noticed that my technique has changed dramatically, but not in one day. It has evolved. I've been doing it now for over 5 years. So my technique has changed. So how has technique evolved and why? If you start doing an eTEP based hernia surgical practice, how do you start? What are the cases to pick up? What are the problems you can encounter? How do you proceed and safely use it to increase your own practice? Should you do a TARM? Should you do something else? Or can you do other eTEP access variants? So eTEP doesn't mean just eTEP as I've shown you. It could be eTEP lateral to the linea semilunaris. It could be eTEP with the ports just lateral to the linea alba and going only on one side. So you don't touch one side at all. You touch only the other side. And typically you do a TAR on that side. So this is another variant. You can do a bottoms up eTEP. So the ports from below and go all the way up to the xiphoid. This is the third variation. You can do a hybrid. So part of it is eTEP, part of it is open. So that is another fantastic way. You can use the robotic platform for fantastic procedures. And the last one is what I'm calling as the stapler, which is stapled retrorectus approach. So the eTEP stapler means eTEP stapled retrorectus repair. So I will be talking about this on the 11th of April, the eTEP stapler approach. So dear friends, if you want to know the answers to all these questions, you must acknowledge that you are a beginner. I continue to acknowledge that I'm a beginner. I have plenty to learn. And one of the people I hope to learn from is you. So please don't stop teaching me, because I will not stop learning. I'm only too happy to discuss cases, discuss complications, management, and talk to you directly on phone, have a video conference. I have had surgeons calling me on video, and I have helped troubleshoot complications or evolving situations in the operating room. And I'm always game to help a colleague and friend in need. Okay. And that is the end of my talk. Thank you very much. So I hope there are questions. I see lots of messages, but I have not been able to see a single one of them. So in case you have them, to be discussed, please, let's go ahead. So,
Dr.
yes.
Kirpan this side.
Yes, Mukund.
Yeah. So this is regarding like how to differentiate between the posterior lamella and the upper neurotic part of the transverse abdominis when you are doing either a bottoms up TAR or a top down TAR, and when we are approaching the lower half of that part. So at times it is becoming difficult to differentiate between these two anatomical structures.
Right. So at that level, they are typically too thin and too fused to divide. So it just becomes one thin aponeurotic sheet, and the differentiation becomes better as you go cephalad when the transversus muscle fibers start coming in between them. So Harsh Seth, you have a question?
Sorry, just one second. Hello? Yeah.
Yes.
Can you hear me?
Yes.
Yeah. Typically an eTEP for a midline hernia, which is either umbilical or infraumbilical, I've faced not much trouble doing them, but it's the supraumbilical hernias with the same port placements which kind of get to me. I've done a couple of them and I've really struggled with the dissection. So are there any tips or tricks from your end that you can suggest to do those supraumbilical hernias with the eTEP approach?
Yeah, so I would say the first thing to do is start from top down, like the typical eTEP ventral approach. Create the retrorectus tunnel and go into the space of Retzius, then put your hypogastric ports. Then shift your camera below and look up. So this would be a better way. Today, I wouldn't bother. I would start from below up. But below up is a separate learning curve. And I will share with you the below up approach as well, because this was part one of what is an exhaustive treatise on eTEP axis.
Maybe one can do like one suggestion, one can do like an eTEP inguinal approach. So
Yes.
one can start like an eTEP inguinal approach, dissect into the pelvic area, hypogastrium, and then put a ports infraumbilical and go cross over to the opposite side and do a bottoms up dissection.
Yes, you could. What happens then is potentially you have a large 12 mm port somewhere in the middle, around 3-5 centimeters above the umbilicus. But you could do it. There's no problem. Okay.
Okay, great. Thank you.
Sure. So the question now is, can you make the whole retrorectus space by balloon only? No. Please do not try balloon space creation for the retrorectus, because the space is so narrow that you will tear the linea semilunaris. So please don't try to do that. The space is limited. The balloon is too much. You just need to do telescopic dissection or instrumental dissection. The balloon dissection is for the space below the arcuate line. For eTEP inguinals, that's a good thing to do, not for eTEP ventrals. Okay, so Rajiv, I don't see questions clearly. If you can see any important question we need to discuss, please say it out. Mukund, you were saying something.
Yeah, I'm saying one more query from my side is, when you do a TAR and when you do a supracostal dissection, so what are the landmarks you should know that where to stop doing that dissection in the supracostal part?
So this is
where one should
pretty
end that dissection of TAR
yes.
in the supracostal part.
Yeah, so this is pretty advanced stuff. So you are looking from below up and you are doing the TAR. Now incline more towards the midline, and there is a transition zone between the transversus and the diaphragmatic fibers. Typically, there is a little bit of fat there. So if you can identify that, stay there and keep pushing the diaphragm away and keep dissecting underneath it. So you're well past the xiphoid now, you're well past that subxiphoid fat till you reach the central tendon. So that is the ideal way of dissecting it. Does that answer your question, Mukund?
Yeah, thank you.
Yes. So is there anything else?
So, hello.
Yes.
Dr. Sandev wants to know where do you make the third port? Is it just above the arcuate line or below it?
It is above the arcuate line typically. It is the port positions are very flexible. It depends on the patient's body contour. If it's a very short patient, you may find that your third port is well below the umbilicus. Whereas if it's a tall patient, you may need to actually stagger your ports so that you have access to the space of Retzius and the space of Bogros. So you may need to shift the ports a little below, or you may need extra long instruments to go all the way down. But the third port is above the arcuate line. Okay, anything else? Rajiv? So I can't see too many of these questions. There are plenty of comments and questions. So I suggest that, when I post this recording on Facebook in the AWR group as well as the Learning General Surgery group, so please shoot your questions. I'm trying to copy the questions. And Rajiv, if you can copy these questions, then it would be good. You can save them and then we could answer them later. Okay, I think we have another lecture in LGS and I will end the meeting today. Thank you very much for your patience, and please give me feedback whether it was too long, too boring, or too technical, or it wasn't interesting enough, not evidence-based enough, or I need to grow my beard a little longer. Please let me know. Okay, have a good day.